Hello, I'm Maud Asya, and I would like to talk about the APX 200, a novel pupil dilator, which was designated to provide pupil dilation in cases of small pupil or IFIS. The principle of the device is quite simple and intuitive. Imagine that you have a small rubber band and you would like to open it up. What one would intuitively do is use these two fingers and open up like this. And this is exactly what we do with the APX. The APX is inserted through two opposite 19-gauge stab incisions, which is just a little bit larger than the routine side-port incisions. The corneal incisions should be done parallel to the iris plane. The APX should be inserted into the anterior chamber until the pivot pin is inside the anterior chamber. And then it is slowly opened about halfway until the distance between the distal tips of the APX is approximately the size of the pupil. Then the terminal hooks are located behind the iris through the sphincter, and then the APX is opened up slowly. The APX does not interfere with any surgical maneuver. Even if the instrument, such as a chopper or iris hook, is overriding an arm of the device, there is no problem, and the APX does not interfere with surgery. No intraocular manipulations are ever required, either to position the APX or to remove it. Now, I did over 50 cases so far, including some very complicated cases. I use the APX in cases of pseudoexfoliation, patients with uveitis or posterior synechia, mature cataract, hypermature cataract, and one case of Mongolian cataract. I use it in cases of narrow angle and post-angle closure glaucoma, two eyes of a patient with denophthalmos, a few cases of IFIS, intraoperative floppy iris syndrome, also cases of coloboma. I use it to do scleral fixation and glued IOL. I used it in a couple of subluxated lenses using capsule stabilizing device, and in 3 cases combined it with pulse planar vitrectomy. The trocars are usually inserted before the APX, and the surgeon should plan the position and the location of the trocar prior to the surgery. In all cases, the pupil was effectively dilated, and all operations were completed successfully. There was no case of any device-related complication or adverse event. For a surgeon sitting in the superior position, it might be a little bit tricky to make the nasal incision because of the nose, or to insert the APX through the nasal side. My personal preference is to work at the superior position, and I ask the patient to look a little bit to the temporal side. And then when the eye moves a little bit, it's quite easy to insert either the knife or the device. For a surgeon working on temporal approach, it might be a little bit difficult to work in deep set eyes and insert the APX at the 12 o'clock position. Then you can just ask the patient to look down a little bit, and then it's much easier to insert the APX.